Please start, Doctor.
Thank you. Good evening, everybody, and nice to see you all again. So today's topic is going to be assessment of double outlet right ventricle. We'll also, sort of look at the types of DORV, etc. as we go on, and hopefully this will be in preparation for the next talk, which is surgical strategies to treat double outlet right ventricle. So before we set out to assess double outlet right ventricle, we need to know what is double outlet right ventricle. There are several definitions that are floating about. The traditional definition is defined as a discontinuity between the posterior semilunar valve and the mitral valve. So when you say posterior semilunar valve, it can either be the aorta if the arteries are sort of normally related, or it can be the pulmonary valve if the arteries are transposed. In addition to the discontinuity between the valves, there is also a 50% override of the semilunar valve, so that the posterior semilunar valve arises, at least 50% of it arises from the right ventricle. So this definition is generally preferred by many, although more recently, there is this feeling that mitral valve and semilunar valve discontinuity is perhaps not that important a feature, and that the challenges of treating or surgically correcting double outlet right ventricle are predominantly faced due to the extent of displacement of the valve. So the other alternative definition is of double outlet right ventricle is where one great artery and at least 50% of the other great artery both arise from the right ventricle. Now, double outlet right ventricle can exist along with normal concordant AV valves. It can exist along with an atretic AV valve, that is only one or a single AV valve that is present. It can exist along with AV valve discordance, or with double inlet left ventricle. Now, if you look at the last three of this list, when you have a single AV valve, automatically the patient is going down the single ventricle route. When you have double inlet left ventricle, automatically the patient is going down the single ventricle route. And with AV discordance, again, it is often a very complex heart. So these patients will automatically fall within the single ventricle category most often. Okay, so the decision making that lies with surgical treatment of double outlet right ventricle is often deciding whether a patient goes down a biventricular route or a single ventricle route. So for the purpose of this talk, we will restrict ourselves to double outlet right ventricle with normal concordant AV valves. Okay, so echocardiographic assessment of double outlet right ventricle aims at 1, establishing the diagnosis, i.e. saying that it is double outlet right ventricle. We already know what are the features to look for. One being mitral discontinuity with the posterior semilunar valve, and the second one being at least 50% of that semilunar valve taking off from the right ventricle. So that is the first step to establish the diagnosis. The second step, like we mentioned earlier, is to assess whether the left ventricle can be routed to one of the outflow tracts. Now, this can be either the pulmonary artery or it can be the aorta, depending on the anatomy and the arrangement of the great arteries. And this will help us whether the VSD is routable to the outflow tract, will help us to decide whether this patient goes down a biventricular strategy or a univentricular strategy. The general dictum being we try and take patients down the biventricular strategy because we feel that the long-term outlook is better for these patients than those that go down the Fontan route. And last but not least, we have to look for associated lesions. So these are associated lesions can be additional VSDs, They can be stenosis of the outflow tracts, either the pulmonary outflow tract or the aortic outflow tract, and of course arch lesions, which should never be forgotten. So these are the three main aims of echocardiographic assessment. So firstly, when we look at defining double outlet right ventricle, we talk about aortomitral continuity. Now I'm hoping that this plays. So yes, now that it's loaded, you can see that on this video clip, this is the aortic valve, this is the mitral valve, and you can see how there is aortomitral continuity. Okay, so there is fibrous continuity between the aortic and the mitral valves in this particular echo image. It is an apical 5-chamber view, which is often quite useful for this purpose. The other view that is again useful is your parasternal long axis view. Now here we have an example of aortomitral discontinuity. Now here you have the aortic valve and here is the mitral valve. Between the two you see a fibrous wedge of tissue. So there is, in this patient, fibrous discontinuity between the mitral valve and the posterior semilunar valve, which in this case is an aortic valve. So like I mentioned before, the parasternal long axis view is a good view to look at this aortomitral continuity or discontinuity. So this is just a labeled illustration of the same. So you see here highlighted that there is a gap between the mitral valve and the posterior semilunar valve, and there is a wedge of tissue in between the two valves. So once you have established the diagnosis of double outlet right ventricle, i.e. the at least 50% of the posterior vessel, great artery arising from the RV, along with 100% of the other great artery, along with that you have the mitral discontinuity. Then you go on to deciding what category this DORV falls within. Now double outlet right ventricle can be classified based on, one, the position of the VSD. Now a VSD is mandatory in a double outlet right ventricle, and flow has to be from the LV to the RV. It's an obligatory shunt between the LV and the RV, from LV to the RV, because the outflows predominantly arise from the RV. So classification depends on the position of the VSD and the great artery relationship, and based on the various combinations and permutations, you have a whole a list of possible varieties of DORV. Some are more common than others, but the classification is based on position of the VSD and great artery relationship. In addition to that, you can have presence or absence of outflow tract obstruction. The most common outflow tract obstruction is pulmonary stenosis, although LVOT obstruction is also possible. And of course, you have to look for presence or absence of additional VSDs. But the primary classification of DORV is based on the position of the VSD and the great artery relationship. So if you look at these illustrations, you can see the various common positions of VSD that you can find in DORV. Here you have the most common type, which is the subaortic VSD. Here you have the subpulmonary VSD, and this part is called the thoracic Bing anomaly. And then the third image is one of the remote VSD. Now, remote VSDs are often inlet VSDs, and sometimes they can be muscular VSDs. The key factor in an inlet type VSD is to look for AV valve straddle, okay, and presence of AV valve between the VSD and the outflow tracts, which could become a difficulty at the time of planning for biventricular repair. The other VSD, of course, that we haven't shown here is the doubly committed VSD. This is quite rare, but these are the types of VSDs that you can find in DORV. So based on these 4 types of VSD, and of course the various great artery relationships that we are aware of, which is side-by-side arrangement of great arteries. This is the most common type of great artery relationship in DORV. Normal great artery relationship, D malposition of the aorta where the aorta is anterior and to the right, and L malposition of the aorta where the aorta is anterior and to the left, which is very rare in this particular anatomy. These are the various different permutations and combinations that are possible. Now, based on these, we can have 16 different types of DORV. Some of them are very, very rare. So I think our focus should be on the commoner varieties, because these are the ones that we are likely to come across, and these are the ones in which we have to make decisions. So as we know now, we know that the subaortic VSD is the commonest type of VSD, and side-by-side arrangement of great arteries is the commonest type of great artery relationship. So the commonest variant of DORV is when you have a subaortic VSD and side-by-side arrangement of the great arteries. Okay. Now, you can also have normal great artery relationship in DORV, and often this behaves either like a VSD or tetralogy of Fallot. Okay, depending on whether there is pulmonary stenosis or not. Now, when you have normally related great arteries, the other types of VSDs are very rare. Okay, so the only or the main type of VSD that you find with normally related great arteries is the subaortic VSD. Now, with side-by-side great arteries, you can find the other less common VSDs, and when you have a subpulmonary VSD, what happens is that blood flows from the LV into the pulmonary artery. These patients have lower saturations because the oxygenated blood, instead of going into systemic circulation, is preferentially going into the subpulmonary circulation. They also develop pulmonary hypertension early. There is no PS, and also can be associated with arch abnormalities, because most of the flow is going into the pulmonary artery and not enough flow is going into the aorta, therefore giving rise to a substrate for coarctation and arch obstruction. So these patients where you have side-by-side great arteries and subpulmonary VSD would behave more like patients with transposition and VSD. Now, remote VSDs can be seen often in association with heterotaxy, and like I mentioned before, VSD is usually in the inlet septum. And what we have to look for when we have a VSD in the inlet septum? AV valve straddle. Then we have the next great artery relationship, which is D post aorta, where the aorta is anterior and to the right. Now, this can happen fairly commonly, and when you have a subaortic ASD, and it can require a conduit placement. When you have a D post aorta with subpulmonary VSD, this is otherwise called a toxic Bing anomaly. And here the physiology and management is similar to that of transposition with a VSD. So in this fashion, as you can see from the table, there are several varieties of double outlet right ventricle. But I think we should focus on the common ones, because these are the ones that we are likely to come across. So like I mentioned before, double outlet right ventricle can behave either like a straightforward VSD, it can behave like tetralogy of Fallot, or it can behave like transposition. So physiologically, it can behave like one of these lesions. So just an illustration of how you can have transposition-like physiology in double outlet right, and how it's a continuum. So you have just a normal heart at this end. You have TGA, where the pulmonary artery arises from the LV and the aorta from the RV with a VSD. This can be associated with sub-PS or PS, and you see that this can quite easily become double outlet right ventricle, and it will continue to behave like TGA PS. So here this is DORV TGA PS, but it behaves like TGA PS because the physiology is, and the streaming is quite similar to transposition. Similarly, you have tetralogy here, and this is double outlet right with a subaortic VSD and PS, and that behaves like tetralogy. So physiologically, it behaves like tetralogy. If you did not have PS, physiologically this will behave like a VSD because there is no restriction to pulmonary blood flow, so this will behave like a VSD. So assessing double outlet right ventricle are the subcostal views, which can either be coronal or sagittal. They are very useful. And then the long axis and short axis parasternal views. These are the key or the important views, particularly when looking at the VSD and addressing rootability issues. Of course, you have to perform a complete echocardiographic examination where you look at the arch and look at all other anatomical features. But these are the key views to help you in the decision making regarding rootability and whether a patient with double outlet right ventricle is suitable for biventricular repair. So if we look at the group of patients with double outlet right ventricle and subaortic VSD, as we know, great artery arrangement, side-by-side great arteries is the most common variant. So here again is an illustration of the subaortic VSD. Here you can see how the left ventricular blood flow is directed almost directly into the aorta. So these patients will have good saturation. Of course, because the pulmonary vascular resistance is low, there will be more than normal flow into the pulmonary arteries, and this patient will behave like a VSD. If there is PS, this patient will behave like tetralogy. Now, this here is a subcostal view. Okay, it's a subcostal sagittal view with the probe, the echo probe, which is placed with the pointer of the probe sort of pointing upwards at 90 degrees. So here, this is the image that you get when you do a subcostal sagittal view. This is the LV, and this here is the RV. You can see the ventricular septum, the crest of the ventricular septum, and you can see the aorta here with the subaortic VSD. Now, just looking at this image, you can clearly see that this aorta is probably rootable, that you can place a baffle or a patch here, and that LV can be committed to the aorta. And this is just a running image of the same. Okay, once again, double outlet right ventricle, you see the two small arrows there are pointing towards the aortomitral discontinuity. So you can see that this satisfies the traditional definition of double outlet right ventricle. You can see that the aorta almost completely arises from the RV, but you can see that the VSD is probably rootable to the aorta. So the aorta can be rooted to the LV, and the VSD appears large enough so as not to cause left ventricular outflow tract obstruction. So these are the considerations, and there appears to be no AV valve tissue or coronal tissue in between. So this appears to be a rootable DORV with a subaortic VSD. So I think these points we have already discussed. Excellent. So this is the DORV with a subaortic VSD which appears rootable. Now that was the subcostal sagittal view. Now here we come to the coronal view. That is, we keep the probe flat on the abdomen with the pointer pointing towards the left of the patient, and this is the sort of image we get. We get a side-by-side arrangement of the great arteries. Because they are at the same plane, so they are just laid just beside each other. So you get this sort of appearance where you have the aorta and the pulmonary artery just next to each other. Here the aorta is to the right of the pulmonary artery, and here you can see the outlet septum, the coronal septum, and this is the RV. This is where the VSD enters. So this is just a moving image of the same, once again illustrating the same features. So the aortic valve, the pulmonary valve, the coronal septum in between, and again you can see how the great arteries are side by side. So once again, this text just explains whatever we've just discussed. So that is, these are two important views to look at double outlet right ventricle, the subcostal, sagittal, and coronal views, and that was a subaortic VSC. Now here you have a short axis type view, and basically this helps to tell you the relationship of the great arteries. Now ideally you want to have this view at valve level, but here the great arteries are laid sort of pretty next to each other, so side by side. The PA, as you can see, is large. So here the physiology is probably that of a VSD rather than tetralogy. So the short axis view is good for looking at the arrangement of the great arteries. Now 3D echocardiography is increasingly becoming a valuable tool in assessment of double outlet right ventricle. So these are just 3D image acquisition planes, and once again you can correlate very beautifully with what you've seen on 3D. On 2D. So these are the image planes. So this is the initial. Once again, you've seen this image before just on 2D. These two images. This is the subcostal, sort of sagittal, coronal type views, and this is the 3D reconstruction of that. So you can see this is the RA, RV. You can see the VSC here beneath the aorta, and you can see the RVOT with the pulmonary artery. And once again, this is just more magnified and labeled for easy appreciation. You can see the aortic valve here, the right atrium, the right ventricle. You're looking at the right ventricular surface, and you can see beautifully how that VSD is opening beneath the aorta. So 3D is increasingly becoming a very useful tool, and recently, I think just very recently, a paper has come out from Guy's Hospital just on this topic of 3D assessment of double outlet right ventricle. So it's worth a read for those of you who are keen to get into 3D echocardiography. Now, of course, we have to look for additional lesions, and this is double outlet right ventricle with a subaortic VSC with PS as well. Okay, so this is another subcostal sagittal view, which is tilted more towards the left, and it shows the right ventricular outflow tract or the pulmonary outflow tract with subpulmonary and pulmonary stenosis. So this patient will behave like a tetralogy of Fallot. So these patients who have double outlet right ventricle with subaortic VSDs, although you would think from a 2D image that just a straightforward patch would close that VSD, actually they need a bit of a baffle, so an incomplete tube really, to form a baffle or a tunnel between the VSD and the outflow tract. I'm sure that Dr. Iyer will go into the surgical aspects of treatment in his talk, so I will not dwell on it at great length. So next subgroup is our double outlet right ventricle with subpulmonary VSD, and when there is a demalposition of the aorta, it is called a toxic Bing anomaly. And here you can see from this illustration that the VSD is now subpulmonary, and from your subcostal sagittal view, you can see how the VSD now opens beneath the pulmonary valve. So this is just a moving image of that still picture, which shows a dilated pulmonary artery with increased flow and a bit of turbulence. So once again, a subcostal sagittal view. Obviously, one has to identify the great arteries. So, I mean, it is often difficult to show you in a single moving clip that this is indeed the pulmonary artery, but it is. You have to take my word for it. But you can see how you have the aorta and the pulmonary artery. You have the outlet septum in between. and you have the VSD just here with the LV flow going directly into the pulmonary artery. So in this patient, you will have lower saturations because of unfavorable streaming of blood. You will have an early incidence of pulmonary vascular disease if there is no PS, which is not there here. Also you could have arch abnormalities because a lot of blood is flowing into the lungs and not enough into systemic circulation. So these are the associated problems to expect with a subpulmonary VSD. Okay. So this is a long axis parasternal view, once again with a subpulmonary VSD, but in this patient there is PS as well. You can see from this image that there is the pulmonary artery is smaller. For some reason it doesn't seem to want to run. Not entirely sure why. But this is double outlet right with VSD and transposition with PS. So this, as you may remember, is similar to TGA VSD PS. Okay, so the only difference is that there is fibrous discontinuity and that the great arteries predominantly take off from the RB. So it's part of the same spectrum as TGA VSD PS, and it behaves like TGA VSD PS. So this is again just views of parasternal long axis and short axis in DORV with subpulmonary VSD, and this patient has PS. You can see clearly just from the size of the pulmonary artery that there is PS, and there is some subpulmonary obstruction as well. This is the aorta, which is anterior and to the right, and the pulmonary artery, which is smaller, appears to be a bicuspid valve probably, and it is posterior and slightly to the left. So in these patients, you can either carry out a VSD closure with arterial switch if there is no significant PS. It is easier to commit the VSD to the pulmonary artery. Let me just see if we can see some pictures of it. Sorry. So it is easier to commit the VSD to the pulmonary artery than it is to the aorta. So what you can do is just as you do in TGA VSD, you know it's quite difficult, isn't it, to route the LV into the aorta here. Instead, you just route it to the pulmonary artery and you switch the great arteries. This is when there is no PS. When there is PS, you have to think of alternative strategies. So then you have to come up with REST-LE or REF procedures. The REV avoids using a conduit, which is a problem, obviously in a small child. Conduits have their own difficulties and need frequent replacement. But the REV could be an alternative where you directly connect the PA into the RV anterior surface, as you see in this illustration. So these are the various surgical possibilities for these patients who behave like transposition, where the VSD is subpulmonary, either with or without pulmonary stenosis. Next, we come to the group of patients who have a remote VSD, and we said that these patients could either have an inlet VSD or they can have a remote muscular VSD. So, as we mentioned before, the important thing with patients with an inlet VSD is to look for AV valve straddle. So, here you see an illustration of a remote sort of inlet VSD, and then we'll try and show you some images of it. So this is the patient with, you can see the apical 4-chamber view shows that there is no AV valve offsetting. There is a large VSD here in the inlet septum. You can see some tricuspid valve tissue reaching out to the crest of the septum. This is a long axis parasternal view. And here again, you see this is the mitral valve, LV, and you can see bits of tricuspid valve coming in to attach to the crest of the septum. So there is a degree of tricuspid valve straddle in this patient. Now, very same patient, question of rootability. So this is the aorta, okay, that you can see. And on this image, you can't really see the VSC. To be routable to the aorta. I can hear some noise. Can people just mute their microphones? That would be helpful. And on this view, the VSC appears routable. So it's a little difficult really in this patient. In patients with inlet or remote VSCs can be quite a challenge surgically. And again, I think the surgical strategy will very much depend on the unit and the surgeon and the team as to what they feel comfortable with. Sometimes it is better to do a single ventricle repair than to do a bad biventricular repair. So I think we have to bear that in mind. One cannot be too aggressive about promoting a biventricular repair if the unit is not geared for it, and then you end up with outflow tract obstruction or problems, then you've probably done a great disservice to the child who may have lived quite happily with a fontan circulation and two good, well-functioning ventricles. So we have to be careful about how aggressive we are with promoting biventricular repair, depending very much on where we work and how we feel as a team about taking these patients on. So when it comes to inlet type VSCs, there are various techniques that are possible. One of them could be to use multiple patch in this really complex fashion. So you can see what I meant when I said it depends very much on individual expertise or a unit expertise in dealing with these patients. And again, another strategy would be to actually route the VSD. Here, the VSD would be if the tricuspid valve comes in between the VSD and the aorta, therefore the VSD is routed to the pulmonary artery and then a switch is performed. So each patient has to be individualized and decision making has to be individualized, but various innovative strategies can be used to deal with these patients. But like I said, a poor biventricular repair is not acceptable. You cannot offer a good biventricular repair. A single ventricle strategy is better in complex patients with remote or difficult to route VSCs. So we talked about additional lesions, and here we have an additional sort of muscular VSC in addition to the VSD higher up. And this has to be dealt with as well. So, all these additional factors can play a part in your decision making. Not only the position of the VSD, but the size of the VSD is also important. Now here you see that this is the aorta. These orange arrows indicate the aorta. These white arrows indicate the VSD. You can see how if you put a baffle across here, the VSD will actually restrict the left ventricular outflow tract. So in this case, it is important to resect that outlet conal septum in order to open that left ventricular outflow tract out and to avoid left ventricular outflow tract obstruction. So it is important when you do your echocardiographic assessment to look at the size of that VSD and look at the potential for left ventricular outflow tract obstruction. So if you look at, what are the factors that prevent two ventricles repair? Now, of course, you need two good-sized ventricles. That is mandatory. You need good AV valves. So these are two mandatory factors or absolute factors. So if you have AV valve stenosis or you have hypoplastic ventricles, it's an absolute no-no. You can't go for a biventricular repair. All other factors are slightly subjective. So is there AV valve straddle or not? Like the patient we saw, the image we saw with the inlet VSD and the AV valve, tricuspid valve inserting to the crest of the ventricular septum, that degree of AV valve straddle may be manageable. It may be that the surgeon can deal with it. He may be able to disconnect the cord and reattach it. So AV valve straddle, although it's a relative contraindication, it is not an absolute contraindication. Unrootable VSC. So what do we call unrootable? Like I said, it is very much unit dependent. So a VSD that appears or that is rootable to one team might not be to another. and you have to individualize it based on your own local circumstances as to whether a patient is operable or not. Now, presence of conal septum between the VSD and the aorta, that is something that people can deal with fairly easily, so it can be resected most often, and it's usually not a problem. AV valve tissue between VSD and aorta is more of a problem, and that can be an issue and could prevent you from performing a biventricular repair. When you have a very large VSD, almost like a single ventricle, or you have multiple VSDs, these can be factors that prevent biventricular repair, and perhaps the risk of long bypass time, very complex operation versus performing a good single ventricle surgery, has to be weighed. Of course, economic considerations are very important. Our patients cannot afford multiple reoperations, particularly when you're using conduits. You have to bear in mind that there is a life to the conduit, and these patients are going to come back to us. So, we are just seeing these patients often during their early childhood. Remember that they have a life to live, and they will continue to have problems. And to a certain extent, consideration has to be given to this factor as well. The one important feature that has some bearing on the rootability of the VSD is the distance between the pulmonary valve and the tricuspid valve, as to whether an aortic valve can be routed to the LV without causing right ventricular outflow tract obstruction. So the closer the pulmonary valve is to the tricuspid valve, then the more likely you are to need a conduit. So this is one of the factors to look at during the time of your assessment. So if you look at the summary of echo assessment of double outlet right ventricle, so important factors are: one is the location and size of the VSD, the rootability, which depends on the location of the VSD, whether there is AV valve tissue in between the VSD and the aorta, and finally whether there is conal septum which needs to be resected. And last but not least, outflow tracts, the arrangement of the outflow tracts, and the presence and the severity of any obstruction. So based on all of these factors, a surgical plan has to be made. In addition to transthoracic echocardiography, we can use transesophageal echocardiography sometimes, and that can give us more detail on the, particularly in patients with poor echo windows or where we're very borderline and doubtful. A TE can sometimes be useful. As we saw in our earlier images, 3D echo is fantastic, and I think as more and more of us start getting familiar with it, it just gives you a much nicer visual appreciation of the, of course, I think a lot of people would argue that we can mentally make a 3D image, but I suppose it's just nicer to show the surgeon, an almost anatomical image. MRI is the other tool which can be quite useful. And in those patients who we are taking down the single ventricle pathway, a cardiac cath may be required. So I think that sort of brings me to the end of my talk, and I'll be happy to take any questions that you have at this point. Any questions at all? Any clarifications, questions? Please feel free to ask. I haven't really, obviously it's important to look at things like branch pulmonary arteries, coronary arteries, especially when you're planning to do a tetralogy type repair. You have to look at coronary arteries. So all these other factors, the arch, all of these have to be looked at. But the talk was focused more on the DORV, specific DORV aspects. Thoracic thing predominantly refers to a subpulmonary VSD, and I find it sometimes very difficult, with side-by-side versus slightly anteriorly placed great arteries. Even on echo, I think if you ask 10 people to give you an opinion, there will be a difference of opinion. So I generally take it as a heart with a DORV with subpulmonary VSD with unrestricted pulmonary blood flow. So that's what I would call a tau signaling heart. But I think traditionally it's the null post. Okay. Any other questions?